Okay, it's Dr. Buford. We're just getting started on the left shoulder. We're looking in from the back to the front. Everything that you see is magnified 30 or 40 times on the screen. The gray cannula that you see coming in, just to give you an idea of the magnification, the opening in that gray cannula is about 5 to 5.5 millimeters, okay? To the right of that is the long head of the biceps tendon. And we can see that inserts down into the labrum here. As we tug on it, pulls away a little bit, but this is not a slap lesion. This is a normal amount of play. There's some other things that we look for arthroscopically to make sure, and we don't see any cracking in the cartilage here. See how the cartilage looks normal? No signs of any problem. The inner edge of this labrum looks normal, right in front of the biceps anchor. So I would say this is not a slap lesion and does not require repair. Although on an MRI scan, this may show as having a sulcus, because you can see as we displace it, there's a little bit of a gap there. Okay, but again, no signs of any chondral injury or trauma, and the soft tissue of the labrum looks normal too. So this is an example of an MRI scan that may be read as a slap tear that really is not. Okay, so we're going to look up at the undersurface of the rotator cuff. This looks good here. No signs of any significant damage on the articular side. I see a little bit of yellowing. See just above the gray cannula how that color is a little bit different than over here. So we can appreciate that arthroscopically. We'll look at that from the bursal side. As we come back around and look at the posterior aspect of the joint, this looks pretty good. Here's the posterior joint capsule. You can look at the insertion into the humeral head. No signs of any significant injury to the cartilage. And then here's the glenoid, which also looks like it's in pretty good shape. I'm going to go ahead and take a probe or something small, guys. The anatomy in the front of the shoulder. Shows us the, I'm going to rotate around and show you a little bit better. So here we go. So there's the middle glenohumeral ligament, this little wispy thing. This is the middle glenohumeral ligament. The tip of that probe is 1 millimeter. So we're talking about a structure that's 2 or 3 millimeters wide. It's really just a thickening in the capsule. And here it is right here. So this is the middle glenohumeral ligament. And just to give you an idea of the size again, there's the 18 gauge spinal needle, so you can see how that's even, the spinal needle is wider than the ligament here, okay, for orientation. Okay, to the left of that, and crossing it at a 45-degree angle, is the superior edge of the subscapularis tendon. And so the subscap is going to be behind the middle glenohumeral ligament here. See how my probe's underneath? So the subscap is going to be this structure that I'm touching with the probe, all back here. It runs at an angle from about 7 o'clock on the screen up towards about 1 o'clock. And as you rotate and look down this way, we'll get another look at it. This is the subscap tendon right here. That's the superior edge of the subscap. That's the very top of the subscap. Okay? And then of course it travels down in this direction here outside the capsule. About the superior 1/3 is intra-articular though, as you see. As we rotate the arm, you can see that. So as we look farther down the front, we can see the anterior glenoid here looks pretty good. And then the inferior glenohumeral ligament is this structure right here. Again, just a little thickening in the capsule. That's it, right there. Okay? This little thickening right here. And again, that probe is 1 millimeter. So that's it. So this looks pretty good. We're going to get to work and look on the bursal side in just a minute. I just wanted to show you before we do anything else, this is what the undersurface of the coracoacromial ligament looks like when there's been ongoing impingement. It's one of the things we look for before deciding to do a decompression. If somebody's symptomatic, of course, we can see some redness in the synovial tissue here. But then as we track this coracoacromial ligament down here, we can see how the undersurface of it has been scuffed up a bit, and that's what a ligament looks like if it's been chronically stressed or chronically frayed or abraded, as you can imagine here. See how you can imagine this great cannula. If I kept doing this, it would start to wear down the undersurface of that ligament. So we're going to make another portal with a spinal needle. With our spinal needle coming in. Okay. And again, this is what I'm talking about. This is the undersurface of that coracoacromial ligament. Okay. Now we've got another cannula coming in from the left, which is lateral. This instrument gets hot, and that little central hole in it has suction attached to it, and allows us to remove this soft tissue here so we can then get access to the bone to remove any bony prominences. Okay, so as I hit the button, see how it starts to it's hot. And you'll see how we can just start to melt away the tissue here. Okay, so as we work here, we're starting to see the bone. The burr won't work through the soft tissue. That's why we have to go through this extra step of removing the soft tissue. So right now, let me let it clear up a little bit. Right now what you're seeing, this is actual bone right now as we remove the ligament and the soft tissue from underneath it. We're trying to identify the lateral edge of the acromion here. This instrument is what we use to remove the bone. This is called a burr. See, it's got a sheath on it, and then when I hit the button, it spins real fast like that. And when we touch it to the bone, we're able to just gently kind of remove bone millimeter by millimeter as much as we want. So we're going to stop there, we're going to change positions and show you some more in just a minute. Now we're looking from the side. That great cannula is coming in from the front of your shoulder, if I can manipulate it out of the way here. Hold that. The shaver here is coming in from the back of your shoulder. And we're just going to try and find, remember that ultrasound showed us an area in the cuff that was torn. I haven't seen it yet, so I'm starting to wonder. Although usually the ultrasound's so sensitive, I'm pretty confident we'll see it. I've been guessing it's just far lateral. As we rotate and abduct your shoulder. Yeah, there, see there? So there's the hole right there. Okay, and so that is what the ultrasound showed us. Invariably, the damage to the tendon is going to be a little bit bigger than that hole that we see. But at least now we know that we're in the right place. See, as I rotate your arm, that's the area in the tendon. And we'll show you how we fix that in a minute. Luckily, the rest of the tendon looks great. This part of the tendon looks very healthy. We're going to go ahead and take off a little bit more bone in a minute. So we're just finishing out our decompression. We've kind of leveled out the acromion here at the top of the screen. It didn't require much, just the anterior lip of the acromion. And now we're going to get to work on the camera. They're deciding what to do with this rotator cuff. As we can see now, there it is there. We're going to identify it a little bit better. We're going to clean up the edges because we know that the edges of this tendon are not healthy either. Remember, we saw that yellow area from the articular side. Now we're looking from the side still. We're just kind of lifting up on the tendon to see. This is that yellow area that was seen from the articular side right in there. And you can see how the tear extends a bit more posterior here. So that's why I say the damage is always more than it looks initially. But I still think we'll be able to repair this with one suture anchor. Using this needle partly as a probe, but also just to check where we're going to place our anchor. To orient ethers, siliconal space. I'm going to place our anchor down right about here. Okay. This is our guide for our anchor. A little bit bigger than the spinal needle, as you see. And again, there's the hole. We're going to place this down really right about here. Pulling the difference right. I like that position there. So that's where we are. Anchor, it's important to seat the anchor by pulling back. So that's what we just did. That locks the anchor into the bone, and that is now very secure. So let me get back up into the space here. Keep this in. We're going to work from right to left on the screen with our suturing device, which means we're going to take out our first suture from the left side of the screen, which is anterior. So I'm going to reach in here from the anterior direction with this instrument that we call a crochet hook. To decide which ones you want to work with first. So I'm going to take this blue and white striking first. The instrument that you see here is called a suture hook. It's loaded with a black wire that we call a super shuttle. You can see it there. And we're going to take this hook and pass it along this path right here. We're pulling back on the super shuttle. If you watch slowly, see how it brings that with it. And then it comes out over there. We're going to use what we call a turn to the left next. So we pull tight, and that's going to bring that suture all the way underneath. We'll reach in with the partner stitch. To retrieve the partner stitch, I should say. And we know we want this blue and white stripe from the way over here. Yeah, that's like a good shot there. And here you can see the first stitch that we've tied. We're going to pass another stitch. We're going to pass another stitch right about here. I'm going to rotate. I'm going to look for the muscle tendon junction right about there. I'm going to come in a little bit lateral to that. sure I get a complete grab of the tendon. You can just see it coming out there. That's a pretty good full thickness bite. So we've placed one anchor and 3 sutures. You can see how we're holding down that cuff now. I'm rotating, and hopefully we'll give that a chance to heal. I'm going to make a little hole in the bone with a little 2mm punch to release some of the marrow elements and hopefully stimulate even more of a healing response. But that's that far lateral. Sometimes these far lateral tears are difficult to access because they're way around the edge of the insertion. But as you can see, we've got it repaired. I'm going to take a punch here and a mallet. About placing this. I can just see the punch here. We obviously don't want to affect our anchor, so we're going to punch way lateral. Just trying to get to where I can show you a good image of it. So, hold the camera here for a minute. Can you come down here for me and just lift me off straight up, please? Yeah, that's a pretty good shot there. So we're going to make a little hole in the bone down here. Nope, a little more. So there's one. Rotate towards me. So rotate, yeah. We'll make another one here. Okay, so those are our little orthobiologic bone marrow vents. We're going to turn down the pressure on the pump. So the picture's going to start to get a little cloudy because the pressure's coming down. So you just want to look at our little vents in the bone and just kind of show you how the marrow starts to come out. See the yellow marrow starting to come out there, so that's good. That's where some of the bone-derived stem cells live. So we're going to finish up here and get you back to the recovery room shortly. Good luck to you now. Bye-bye.